nothing else to look forward to, why would the answer not be yes? Thinking about Dr. Hayes' comment yesterday that head and neck was getting the wrong end of the stick, I was like, wow, why don't you wait for small cell? So just to move forward. So the three main areas I want to address with this presentation is really, why should immunotherapy work in small cell lung cancer? And if I said it should, where is the evidence? And if there is evidence, are there other things that people are doing to enhance the efficacy or to hasten the incorporation of this into standard of care? So recently there was a publication from a Japanese group showing that PD-L1 is highly expressed in small cell. And as you can see from their data, they showed that close to 80% of the samples were PD-L1 positive. And that also had prognostic significance, with PD-L1 positive tumor doing better than PD-L1 negative. But the devil is in the details. Because of the way they assessed PD-L1 was really confounding their estimation of the prevalence. Also, the fact that the type of antibody that they use, if you look at the representative slide that was provided, is not necessarily membranous staining, which, as Dr. Hirsch will let us know, that is important to show whether or not it is accurate staining for PD-L1. About the same time was this study out of Europe showing that PD-L1 is not expressed in small cell, whether you look at pulmonary or extrapulmonary small cell. And I think, and they went forward to look at stroma staining for PD-L1, and they showed some correlation between PD-L1 stroma staining and CD68 positive activated macrophages, as well as CD3 positive lymphocyte. They confirmed the same observation using RT-PCR. I believe that the truth is probably somewhere in between. It's not 80% and it's probably not 0%. And I think the most important data that we can refer to now that is out there in the public is the Keynote 28 study, where they actually did systematic staining for PD-L1 in patients enrolled on this study. And as we can see here, they screened about 157 patients in order to enroll 20 patients. So that tells us that the positivity rate is probably somewhere between 15 and 20%. We already saw this slide several times, but what I want to emphasize about this is, even if PD-L1 is not a reliable biomarker, there are other things that people have implicated, one being the mutation burden. And while small cell is not listed on this slide, if you go back and look at the burden of mutation in small cell, it's actually way off the chart. So if there's any correlation between mutation burden and new antigen presence and being able to respond to immunotherapy, small cell should actually be a poster child for that. And this is one of the earliest whole genome sequencing data in small cell line, showing that practically every chromosome that was looked at had some aberration, whether mutation, translocation, or what have you. So definitely, if the eventual biomarker or one of them is going to be mutation burden, I think small cell would have a place at the front row. And before PD-L1 and PD-1 became sexy, people have actually looked at the role of immunity in small cell. This was a small Japanese study in about 100 patients, where they looked at patients with long-term survival versus those with early recurrence, and they looked at the level of activated lymphocytes in peripheral circulating blood. And what you can see here, for those who are long-term survival, activated lymphocyte is a little bit significantly higher than those with early recurrence. When you look at Tregs, there doesn't seem to be any difference, but there is a trend towards higher Tregs in circulation in those with recurrent disease. And a balance between activated and Treg was significantly in favor of those with long-term survival post-frontline therapy. Have we seen this in patients? Yes. When ipilimumab was added to carboplatin and paclitaxel, especially the phased introduction of ipilimumab after several cycles of chemotherapy, there was a trend towards improved progression-free survival in patients who got ipilimumab compared to those who did not. And this has led to a phase 3 randomized study that has completed accrual that we're now expecting the result any moment. in the next few years. So going forward to what we know about PD-L1 targeted therapies and PD-1 targeted therapies. These are two studies presented at ASCO, and one of them was updated at World Lung. Keynote 28 was presented by Dr. Ott, and I showed you what they did to screen 157 patients to find the 20 patients enrolled. This study allowed patients to receive pembrolizumab every 2 weeks, and those who did not have any progression of disease were continued on treatment for approximately 2 months, 24 months. So what was the result? As we all know that patients with limited stage disease at times can present with Eaton-Lambert syndrome, there's always the concern that when you unleash the immune system, you may actually induce neurological toxicity. Reassuringly, in this study, there was no evidence for that, but we also know that this could be a very late effect in some cases, and the median follow-up time as of the time of this reporting was only 21 weeks. How about the efficacy data? 35% of patients had response. Majority of those were partial responses. There were no complete responses, so we're not curing small cell with immunotherapy. But more concerning for me is actually the updated data at World Lung, where the safety data seems to have held up pretty well. There wasn't any additional signal of increased toxicity. But when we looked at the updated efficacy outcomes in these patients, the response rate seemed to have trended down a little bit to 29%. But more importantly, the median progression-free survival was only 1.8 months. This would not even be sufficient for anyone to consider going after topotecan in this setting. It's not all gloomy report when it comes to immune checkpoint therapy and small cell. So Checkmate 32 compared nivo with or without ipilimumab in small cell, in relapsed small cell. We saw this on Dr. Carbone 2 days ago. This actually was a combined small cell and non-small cell study where they were testing different combinations of nivo and ipilimumab at different doses. And they reported the result for the two combination arm and the single agent arm. We still do not have the full result for the high nivo plus low ipilimumab dose yet. This is the comparison of patient on nivolumab single agent and the combination. As what I want to show here is the fact that patients on nivolumab appear to have been more heavily pretreated than those on nivolumab and ipilimumab, but the distribution in terms of platinum resistance or sensitivity was more or less equivalent. In terms of response rate, it was in the double digit, 18% for single agent nivolumab and 15% for the combination, but updated data showed that the addition of ipilimumab actually increased the response rate of about 32%. The median time to response was very quick. Basically, by the time of the first restaging scan, patient that will respond already responded. And interestingly, the median duration of response was not yet reached in those who received nivolumab and was 6.9 months in those with a combination. Intriguingly, when you look at the survival curve, the median overall survival was actually 4.4 months with single agent nivolumab and 8.2 months with the combination, which raises the question whether patients were dying before they progressed, because the median duration of response was much longer. It could just be that some of the patients included in survival analysis were not included in the response assessment. But be that as it may, I think the combination appeared quite promising when you evaluate that in the context of what we have available, which is just topotecan as standard of care. A subset analysis based on platinum sensitivity did not show any signal. And while this study did not enroll based on PD-L1 expression unlike pembrolizumab, they looked at PD-L1 expression between the nivo and the nivo-ipi arm, and there didn't seem to be any difference in terms of the prevalence of PD-L1 expression. So that wouldn't explain the improved efficacy that we saw with the combination. So what else are people doing to further integrate this into clinical practice or to enhance efficacy? We've all heard about the role of radiation therapy as a sensitizing mechanism for immunotherapy. This actually work out of Duke, where they combine immunotherapy and ionizing radiation, and they showed very well that the combination of radiation with immunotherapy was much better than each agent alone. More interestingly, when you re-challenge animals treated with the combination, you actually were able to prevent tumor grafting. And they also demonstrated abscopal effect, whereby animals treated on one side showed evidence of reduction of tumor on the untreated side. Advancing from that, we considered a strategy at Emory to try to understand a little bit better the biology of radiation in combination with immunotherapy. So in collaboration with AstraZeneca, we have these small randomized phase 2 proof of concept study that's going to enroll patients previously treated with platinum, etoposide, or any other frontline regimen, and then randomize them to either receive radiation alone. This would be short duration radiation within a week, or no radiation, and then patient will proceed to receive durvalumab with tremelimumab. There's going to be well-integrated translational component of this with peripheral circulating lymphocyte profiling, as well as tumor biopsy, to better understand whether or not we are modulating the tumor infiltrating environment with the addition of radiation to immunotherapy. The other study that is currently enrolling is Checkmate 451, which is a maintenance strategy in small cell, whereby patient will be randomized following completion of frontline chemotherapy to nivolumab monotherapy, the combination of nivolumab and ipilimumab, or placebo. This study is a global study that will enroll 810 patients. PD-L1 expression is not a requirement, but there is requirement to submit tissue for post-hoc analysis based on PD-L1 expression. There is also Checkmate 331, which is comparing nivolumab to standard of care. This is also a global study that is designed to enroll 480 patients. Patient will be randomized to nivolumab as a single agent, or topotecan in the US, or topotecan or amrubicin in Japan. Both of these studies are currently activated and perhaps enrolling in some sites already. Finally, when you look at clinicaltrials.gov, there's quite a number of studies being conducted in the non-small cell lung cancer space, but there's at least a few being conducted in small cell as well. BMS just completed the randomized phase 3 of EP plus or chemo plus or minus ipilimumab. We should know the results of that very soon. And then the reaction study is actually a European study that will randomize patients to pembro plus platinum etoposide versus platinum etoposide alone. MD Anderson, they're doing a phase 1 study looking at platinum plus radiation along with pembrolizumab to try to establish the safety of this combination. And Dr. Greg Gill at Kermanos also has a single-arm phase 2 study of pembrolizumab as maintenance post-frontline platinum etoposide. The Stimuli study is a somewhat complicated study that will randomize limited stage patients following frontline chemotherapy to nivolumab plus ipilimumab versus chemoradiation followed by just placebo. So in conclusion, there is a small proportion of small cell lung cancer that has PD-L1 positive, which will suggest that if this turns out to be the important biomarker that we live by, then the role of immunotherapy in small cell may be somewhat limited unless we have other strategies to incorporate immunotherapy into the treatment of these patients. However, in those with PD-L1 positive disease, overall response rate appears encouraging, especially with the combination of nivolumab and ipilimumab. Ongoing studies in various settings, both for limited as well as extensive stage disease, would perhaps enable us to further integrate this strategy into the care of patients. And with that, I stop and take questions. Thank you.
You know, the one thing is I used to argue with Tony Greco. He said that you cannot do a third line small cell lymphoma patients. The patients are just in
Ready
terrible
to go.
shape.
Yeah.
And I noticed that like the Pembro data, at least 65% were 2 or more prior therapies. So do you think in that, because I mean these patients often have huge bolts of tumor, that probably because of that really overwhelming immune system, is that one of the reasons these drugs, 1.8 month, PFS? And if that's the case, and we got to go earlier, how do you really recommend trying to integrate this into earlier therapies? I know I saw your study, so that's probably what you're going to say, but what do you really think is the best way to kind of test these to see if they work or not?
I think we need to understand better exactly what we're doing to patients in terms of activating the immune system or taking off the brake. And until we figure that one out, I think we're still playing in the dark. I would believe that perhaps the frontline strategy, some of the studies I didn't list here, there are actually some strategies currently also to incorporate the combination into the frontline setting along with chemotherapy. I think that may offer us the opportunity to catch those patients early. But more importantly is understanding which subset of patients are likely to benefit. And if we know those, then we can tailor them towards immunotherapy and then perhaps look for a different strategy for those that will not benefit. All right. Well.